Thank you, Dr. Sonu, and thank you, AIOS Scientific Committee team. This webinar has been absolutely fabulous and stunning in its own regard. So let me continue with my talk today. My talk today talks about subluxations, and I know there are 100 ways to skin a cat. Probably, I'm just going to show you guys two favorite techniques of mine, which I think I've been using over the past more than probably 3-4 years now, and I think they're very crucial in different elements. Dr. Chi and what Shell just now showed is actually a prelude to whatever I am going to talk on. So thank you so much, Dr. Chi and Shell, to talk about or put the context in what I'm going to talk today. So I'm going to show you two special techniques of mine. One in a milder case is what I do. If you have a look at this, this is a mild. When I say mild case, the traumatic case, in a traumatic case, more than 180 degrees of subluxation. I've started to move over to this paperclip stabilizer, capsule stabilizer, where I'm making a scleral flap on one side. And I'll come to why I'm making that partial thickness scleral flap later. But the purpose here done is actually make a capsulorhexis. After you're done a CCC and performed your hydrodissection, you can see that this nucleus is rather soft in its own way, but there is some rigidity to it, and I'll tell you why. Well, that's important. After that, I've made a sclerotomy approximately 1.25 millimeters behind the limbus there, and I'm placing this PMMA haptic based paperclip capsule stabilizer inside the eye. After that, I'm placing now two capsular hooks to hold that bag in place during my phacoemulsification. This paperclip capsule stabilizer goes under the anterior capsular rim at a 2-point fixation. If you see here, there are 2 points here, which is where it fixes, which is why it's also a little bit safer than for a longer period of time, especially because we'll be leaving this and not touching this even post-operatively. Now I'm using a Gebor-Chariot's tunnel at the base of the flap, and now completing my phacoemulsification. As I told you, this is a rather soft one, but nonetheless, soft or hard, no matter what well, nucleus it is, anytime you remove a nucleus, you will have that bag equator crumpling on itself the minute you remove the nucleus. And that's the important aspect which I want everybody to grab here. So just the paperclip stabilizer is probably not going to be enough. And at this point, I urge everybody, after they are done with their phacoemulsification, to place a capsule tension ring that holds that equator at bay, prevents any vitreous from coming forward, and also prevents any aqueous misdirection, which I think Dr. Chi showed very nicely can happen in these cases, because the aqueous does go behind and hydrate that vitreous, pushing an positive thrust from behind, which is what you want to prevent. Now, after the phaco is done, you actually just remove the capsule hooks and place the intraocular lens in the bag as is. You don't change much. You can actually rotate pretty smoothly because you already have a capsule tension ring. You have your paperclip capsule stabilizer. As you can see over here, it's holding that bag in at bay. And these are the post-operative images of immediate post-op is right here, and I'll show you the first day post-op of it with a 20/20 vision the immediate next day, which is why I'm kind of starting to love this, because I don't have to use any sutures, there's no confusion, and it's immediately over. I don't have to do anything post placing the lens. And this is the post-operative image of day one. This is one case that I wanted to show in a mild scenario what I do. Let's just see another case. And I think this goes on to what Dr. Suhas was talking about just now. If it's a very deeply subluxated lens like this in a traumatic condition, first up, I'm always measuring which way I want to use the glue dial. I know I have to do a glued intraocular lens in this case because it's far too severe a subluxation. But having said that, I also have to remove the nucleus. And in order to remove that nucleus, I'm first making my ports. I've made it at 6 and 9 o'clock. Now I'm using a modified PAL technique popularized by David Chang, and using the modified PAL technique, I'm bringing that nucleus into the anterior chamber using some pilocarpine, and through the ports as well as limbal route, I'm using a anterior vitrectomy. Now, after the anterior vitrectomy is done, because I'm using the nucleus which is more transparent. And I can tell you, I've done even grade 2, almost reaching grade 3 with these, in these scenarios. And I can tell you that you can easily see through these blue haptics under the nucleus. So you really have to ensure which nuclei you can see and can't see. Also, you have to see which grade you want to emulsify. I'll tell you why that is important. But the idea here is to basically do the glued intraocular lens under uh, the nucleus. And once this handshake technique is done and you're able to externalize both the haptics outside, and using the Gabor-Chariot tunnel, stabilize this. Some cases, if it's a pediatric case, I even go and put a suture on that to hold it. And just emulsify this. Why this helps is because, as I think Shell also showed, that you want to do phacoemulsification. You want to have some protective mechanism so that the pieces don't go flying inside the vitreous cavity. The IOL with the small pupil really help you prevent that from happening. Once you're done with this, you can actually also test whether there's any vitreous in the anterior chamber. But fortunately for me, nothing had prolapsed into the anterior chamber here. And what I'm basically doing here is, as I told you, we're done post-operative day 1. These are the two cases which I thought was very important. There are far more. There is one more, but I think in interest of time, I'm going to stop with the mild and severe cases, which I thought was very interesting to show in an audience like this.
Thank you so